broad area of hepatology. And now we move on to another interesting session on management decisions and Budd-Chiari syndrome, which also remains an area of multidisciplinary, complex discussions. So to chair this session, I would like to invite Professor Arunanshu Behera from the Livasa Hospital, Mohali, Dr. Verghese Thomas from Malabar Medical College, Calicut, and Dr. Tarana Gupta from PGIMS Rohtak. So while we are waiting for the other chairpersons, I hand it over to you, sir, for the proceedings.
Mic is okay. I think without much delay, we'll start the session. But I have a request to you because I have to leave to the airport by 1 o'clock. So please find out other chairpersons to take over when I leave. Because yeah, what 1 o'clock I have to go. Okay. So the next is very interesting session on Budd-Chiari syndrome, and the next topic is stepwise versus individualized approach in Budd-Chiari syndrome, and the speech will be delivered by none other than our beloved Yogesh sir. I request Professor Yogesh K. Chawla to deliver his speech.
Thank you very much. Budd-Chiari has been very close to us in the Department of Hepatology, and we probably were the first to publish the largest series of Budd-Chiari way back in 1992. So this is an interesting topic which was given to me. We know that Budd-Chiari syndrome is basically a venous obstruction of hepatic vein and the IVC. And classical hepatic vein obstruction is maybe segmental, web, or diffuse. It's more common in India. And more often, these patients present acutely. Whereas hepatic vena cava Budd-Chiari syndrome, where only the IVC is involved, maybe a short or a long segment, mostly has a presentation of chronicity. But what we get in India is either the hepatic vein block or a combination of hepatic vein and IVC block. The course could be fulminant in 7% of cases where these patients present with acute liver failure, hepatomegaly. Could be acute, duration is about 6 months. Except for fulminant or acute, it's very difficult to identify whether these patients have subacute or chronic type of Budd-Chiari. But 20% of them are asymptomatic. So whenever a thrombus occurs in these blood vessels, the liver injury continues, leads to irreversible portal hypertension and liver failure. And we are all familiar with the primary type of Budd-Chiari syndrome, which is associated in the West with procoagulant states, and secondary through extraneous compression. And mortality is 50% in 2 years if left untreated, and 3-year survival is less than 10%. And usually 2 hepatic veins need to be obstructed for clinical detection. Portal vein thrombosis is there in 10 to 20%. These are some important attributes which we should all be familiar with before we go into the therapeutic aspect. In the West, almost 87% of these patients have a thrombophilic disorder. And if Budd-Chiari is not treated, 10% of them develop HCC. And studies have shown that higher IVC block, cirrhosis, long segment vascular obstruction, these patients are more prone for HCC. And since these are some recent publications, radiological interventions tend to improve the outcomes. One has to differentiate regenerative nodules from HCC, and these regenerative nodules are less than 4 centimeters, more than 10, hypervascular, and disseminated throughout the liver. Now, meta-analysis recently published by Dr. Giri from KIMS showed that the etiology in portal vein thrombosis and Budd-Chiari syndrome is almost almost similar. Idiopathic in 54% with portal vein thrombosis, 55% with Budd-Chiari syndrome. And you have variable hypohomocystinemia, protein C mutations in JAK2, APLA, and one procoagulant disorder in about 46% of cases. So this is important that almost 55% of our patients do not have an etiology. Diagnosis is simple. You do it with the help of a Doppler, but CT and MRI is important to know the vascular anatomy for intervention. And liver biopsy is not usually done. And for the benefit of residents, ascites in these patients is usually high protein with high SAG of more than 1.1. The EASL and ASLD recommend that you should have a medical management, a stepwise management. Medical management, if that fails, angioplasty and stent. If that fails, tips or dips, and ultimately liver transplantation. But we have to know that recanalization improves portal hypertension and prevents worsening of liver function. So step up approach ignores the venous congestion driven chronic ischemia perpetrating necrosis and hepatic fibrosis, which means we tend to lose a lot of time when we look for anticoagulation. And now the current thought is that you have to be faster in doing an approach for managing these patients. This is what the EASL had said. The prognostic indices, which are there about 4-5 of them, none of them have been useful managing these patients on an individual level. So, a puzzle recommends that all Budd-Chiari syndrome patients should be evaluated for inherited or acquired thrombophilic factors. And as I just mentioned, mostly our patients are idiopathic, but if you find an etiology, treat specific etiology, like in MPD cytoreduction therapy or in PNH eculizumab. Now let's come to anticoagulation therapy, which has been widely advocated. The purpose of this is to resolve the clot and prevent clot progression. And this has been the foundation of medical therapy, mostly in the West, for a number of years. But we don't exactly know the timing of thrombosis, so it is not very accurate, except whenever you have a patient with fulminant Budd-Chiari syndrome. And anticoagulation over the years has shown that it has very little role in subacute or chronic Budd-Chiari syndrome unless it is progressive. Only 10% of these patients benefit, and that also if you can pick them up in the early stages. There is lack of randomized controlled trials, and usually occlusion of the hepatic vein or the IVC or complete occlusion of all three hepatic veins is less likely to respond. So this is something that we need to remember. And there is no agreed definition on response to therapy. Yesterday, there was a randomized controlled trial from All India Institute by Dr. Biswas, where they compared anticoagulation with stenting and found stenting to be better. And this is what I'm going to say, that there is an initial response of about 30%, but loss of response later in 1 to 2 years. And this loss of response is associated with high mortality. European multicentric trial, 1 year intervention free survival is 45%, 2 years 35%, and 3 years 29%. And usually the response takes about 2 to 5 months, and continuing beyond 2 months is unrewarding. So there is always a dilemma if these patients have associated high-risk varices. So most of our patients have subacute or chronic with fibrotic or membranous obstruction. So I come to the main therapeutic indication which we should all adhere to, and that is try to bring about an anatomical recanalization with or without stent, because it restores the physiological hemodynamics. And studies have shown that overall survival for 1 year is about 92%, 79% for 5 years survival. And another meta-analysis has shown with angioplasty that technical success is almost 99%, clinical success 97%, 1 year survival 98, and 5 year 94. So it's extremely good. But the conclusion from the meta-analysis is that you could attempt angioplasty if the stenosis is less than 3 centimeters and there is a web. But you should always combine it with a stent when the obstruction is more than 3 centimeters. And enough studies have shown that restenosis occurs more often with angioplasty than when you combine angioplasty with a stent. Meta-analysis, yet another one, shows that 5 year survival after recanalization is 88%. And the only problem with angioplasty is frequent restenosis, which significantly decreases if the patient is stented. And now they have gradually defined the treatment response. There should be flow within the hepatic veins, elevation of the portal hypertension and Budd-Chiari symptoms, and there should be normalization of the liver functions. And this is some Indian data which shows almost similar results to what I just said. So the other good modality is TIPS or DIPS, and this is also known as a derivative treatment, usually done in patients who are not responders to medical treatment. If there is failure of recanalization, if there is refractory portal hypertension, which means the recanalization has not been possible, acute liver failure, if the veins are fibrotic or diffuse. But you have to realize that TIPS is more complicated, and you should avoid if there is portal vein thrombosis, right hepatic failure, severe pulmonary hypertension, and cardiomyopathy. But survival from good expertise centers have shown that 5 year survival is 70 to 96%, and 10 year survival is 76%. Similarly, good results from other studies have also shown that even up to 10 years, these patients survive from 76 to 84%. And study from ILBS recently showed that even with a worse liver function with a bilirubin of 3 to 6 milligram percent, technical success is good and outcome is similar. So, what is better? Anatomical recanalization is better, or TIPS and Budd-Chiari syndrome? The patency is almost similar, survival rates are similar, procedural complications are more with TIPS, hepatic encephalopathy more with TIPS. 72% patients usually respond to anatomical recanalization, 25% need TIPS. But TIPS overall has shown good outcome regardless of timing in good centers. So earlier recanalization is preferred than anticoagulant therapy, which has to be given lifelong. And TIPS should be done as soon as possible, although to know which time for intervention is still difficult. So these are some of the studies in Budd-Chiari syndrome where TIPS has been associated with good results. The rate of events are not very high, and this again is a publication from Giri. These shunts tend to have shunt dysfunction in 60 to 80% after 1 year, but this was at a time when bare stents were used. Now with PTFE stents, it is much lesser. Re-intervention can be done if the TIPS becomes less functional or dysfunctional, and results are good. Hepatic encephalopathy with TIPS and Budd-Chiari is less as compared to those in cirrhosis, and procedure-related complications are 0 to 56%. If somehow TIPS is not possible, then shunt surgery was extremely popular before 2010, and PGI was one of the centers where we used to routinely do mesocaval shunt or mesoatrial shunts in Budd-Chiari, and that was the time TIPS somehow could not be picked up because shunt was the first choice at our place with very good results. But now it is indicated if there is TIPS failure and you're not able to do the TIPS. Liver transplantation is the ultimate in acute or fulminant liver failure if TIPS cannot be done immediately and if patients do not respond to radiological interventions, which happens in 10 to 20% of cases. But since these patients have a coagulation disorder, recurrence is extremely low due to long-term anticoagulants. And post-transplantation survivals have been reported to be very good. 5-year survival is almost 75% after the transplant. And a series of 46 Chiari patients showed even a 20-year survival of 60%. So the results overall are better than what they are reported with other indications of liver transplantations. One study showed a comparison of TIPS versus liver transplantation. The results were almost similar, but the study showed that TIPS was better when used with covered stents. And another large study of 378 patients showed that both are equally good, where you have to individualize the therapy, and there was no association with MELD sodium or prior TIPS with survival. 72% live till 10 years. So, friends, in conclusion, I would say that whenever a patient with Chiari syndrome comes to you, do a thrombophilic etiology and correct the thrombophilia. Try to look at the anatomical sites of obstruction. Anticoagulation, by and large, has unsatisfactory results, but we'll listen to Uday in the next talk about more about this. Recanalization is now the preferred therapy because it gives good results and it's more physiological, and you don't have to wait for a period of 2 months with anticoagulation. It is much simpler than TIPS and DIPS. TIPS and DIPS, if it is possible in experts centers, gives excellent results. You have the option of shunt surgery and liver transplantation, depending on the indications of the therapy in Chiari syndrome and the expertise available at the institute. So thank you very much for your patient listening.
Thank you, sir. Thank you very much. I request you to kindly occupy the chairman's seat as well, because you are the best person to chair this session in my absence. I also request Dr. Haba also to come and occupy the chair, because I have to leave at 1 o'clock. The next session is direct oral anticoagulants in BCS, the current status. It will be done by Dr. Uday Sakaria, Professor of Hepatology, CMC Vellore. Over to Dr. Uday.
Thank you, chairpersons. Over the next 10 minutes or so, I'll try and review where we are with directly acting anticoagulants in Chiari. I want to start with a disclaimer. In general, in CMC Vellore for Chiari, we don't use directly acting oral anticoagulants, but I'll still review what we have so far, which is minimal. So I'll cover what are DOACs. I'll briefly look at what is available in CLD and focus on the data in Chiari, whatever minimal there is, and specifically look at DOACs and bleeding and whether they are associated with DILI. This has been covered time and again from the morning, and it's safe to say that today almost all of us in the audience will agree that cirrhosis, at least compensated cirrhosis, is a prothrombotic condition where you also have portal hypertensive bleeding. So there is a thrombin burst. Thrombin, as you know, is what prothrombin to thrombin is what converts then the fibrinogen to fibrin for clot formation. So there are thrombin bursts, and that is balanced by the antithrombin factors, including activated protein C and protein S. So this was Tripodi's seminal paper showing all the factors. This has been alluded to, but permit me to say again, the elevated levels of 1 Willebrand factor, the low ADAM-TS levels, activated factor 8 on the endothelium. To add to all that, in Chiari specifically, you have primary thrombophilic conditions as well. So it's interesting that it has taken us 15 years to understand this, that the liver is not auto-anticoagulated. So with that, when we look at DOACs, we have in India primarily rivaroxaban and apixaban, which directly inhibit factor 10 and prevents its activation. Or we have dabigatran, which is a direct thrombin inhibitor. When we look at the hepatic metabolism of these drugs and pharmacokinetics, the rivaroxaban and apixaban mainly have a hepatic metabolism, versus dabigatran is almost entirely having a renal excretion. When we look at peak drug levels and exposure in child A and child B, where it has been looked at, rivaroxaban has a slightly elevated peak drug level, versus in the child B situation, dabigatran, it can be slightly lower. The implications of this in a clinical setting are till today unknown. When we look at the INR, there is no role in monitoring, but if you do check the INR, you will expect it to be marginally elevated. But again, the significance of this is not known. So with that, I'll just tell you one thing. This has already been alluded to today about what is happening in cirrhosis, rivaroxaban. I put this up because it was a multi-center trial, though small. And primarily it was looking at whether it can prevent a primary endpoint of mortality or decompensation, given the fact that rivaroxaban may have an antifibrotic effect. But my focus is to show you that most of these patients were child A or child B, 7 to 10. And while, yes, it did prevent decompensation or all cause mortality, there was also bleeding. Even though they say that non-portal hypertensive, no major bleeding, and major bleeding being defined as either mortality or a critical organ bleed, or a hemoglobin fall more than 2 gram, or sorry, I forgot the last one for major bleed. And so there was no difference in major bleeding, but there was, and minor bleeding was still there. So this is what is there for CLD. Now, when we look at the West before coming to India, this was a small study that I could find from the Austrian group, where they looked at, again, a small group of patients, 47 of which primary BCS, 22 were treated with DOACs, including apixaban and rivaroxaban. But again, you can see that there was a major procedure-related bleeding in this group, and that's what we need to keep in mind. The efficacy of the DOACs, what was the interventional radiology procedure was not clear in this paper, but the assumption was that that was also done, and at 5 years there was a good transplant free survival. This is the same paper. The majority of them were females. Most of them were A or B, and 16 of them, 70%, had decompensation at inclusion. A small group had SVT as well. And majority of these patients were switched from low molecular weight heparin to DOAC after stabilization or improvement. Again, an important point to keep in mind. And again, these were the major bleeds: UGI, upper GI, and a HCC rupture. With that, want to take you back home. This paper, elegant paper from the AIMS group, Shalimar. We looked at dabigatran, the direct thrombin inhibitor, as an oral anticoagulant in patients who had endovascular interventions. So here the protocol, it was divided into those who had interventions, and then further divided into 30 who had dabigatran and 83 who had vitamin K antagonists, all matched. And again, here the protocol followed was initially started on heparin, but within 3 days of post-procedure, they were started on dabigatran at 150 milligrams BD on day 3. Again, a young age group, female predominant, almost entirely A and CTPA or B, and the duration of anticoagulation, the median was about 11 months. So this was followed up at 6 and 12 months, and the stent patency rates were no different between the two groups. The major bleeds were no different, but again there were bleeds. And the composite endpoint, which is again mortality, or here again a recurrence of a major bleed, was similar in both groups. And the major bleed with dabigatran was an upper GI bleed with hemopericardium, versus with vitamin K, two of them were intracranial. I want to share a bit of data from down south from Vellore, where Anand Sharma, who's now in the AIMS Rishikesh, looked at anticoagulating Budd-Chiari patients presenting with a variceal bleed. So you had group 1, don't worry about the busy slide. You had group 1 who were patients who presented with a GI bleed, that is a variceal bleed, and group 2 were the ones matched who presented with ascites. Again, they were mainly child A to B. And I'm just focusing on the part, and again, a busy slide, but on your left, you could see that overall the number of bleeds were low, about 4 to 5 bleeds, and it was no different in group 1 and group 2. Group 1 was the group which presented with variceal bleed, remember, and it's interesting to see that the time for the repeat variceal bleed was almost about a median of 800 days, versus in the ascitic group was about 400 days. And this is probably because most of these patients would have had endoscopic intervention followed by radiological intervention. And below you can see the survival curve here. The follow-up is for about 5 years, and what we were able to show that the bleed difference there was no difference in the bleed, even if you presented with a variceal bleed. Now comes the problems that I have. Okay, use a DOAC. But what happens if you have a DOAC bleed? If I use a vitamin K antagonist, my antidote is 2 rupees. It's vitamin K. Versus when I checked last, the cost of idarucizumab, which is a monoclonal antibody which binds to dabigatran, it acts very quickly. It's very good, but the cost is about 1,50,000 to 2 lakhs. Accessibility is a problem. So this is the issue that I have. On the other hand, the antidote for factor 10A, for the anti-10A inhibitors, and Dexinat is just not available in India. So how do we monitor? We like to see a value, but there is no way at present we have a monitoring system in DOACs. So when I use a DOAC, especially in a situation of CLD where I don't know what the protein levels are, am I over anticoagulating? Am I under anticoagulating? We don't know. So it's easy for me to say it's not recommended, but I will have no way of saying whether we have adequately anticoagulated or not. We do have a similar problem with vitamin K antagonists, where the INR is not reliable, but so too with DOACs. Pregnancy and lactation not recommended. There are case reports of drug-induced liver injury. A few reports, most of them are with rivaroxaban, but all of them have it, apixaban and dabigatran. And it appears that rivaroxaban is drug specific rather than class specific, because if you have a rivaroxaban DILI, there's a case report where you shifted it to apixaban and it didn't recur. So here's my summary. Can we use DOACs in BCS? The answer is yes. Should we use it? I am not sure in our country. If you're using it, then it should be in a patient who is close by to you, who has a deep pocket, and whom you know has access to excellent tertiary level care. And even in that situation, I would say use it in the CTP A and B situation. And yes, platelets, whether it's 50,000 or 1 lakh or 30,000, is debatable. For me, I respect the platelet over the PT. So I would stick to 50,000 as of now. Which is the preferred DOAC? Difficult to say. You can choose, but with this Indian data that is there, I would choose dabigatran since it is available and there's Indian data over the other two. And between the other two, it's really a choice that you'll have to take. When do we start it? I know the AIMS group started it within 3 days, but I would say, as was done earlier, after stabilization and improvement. What do I mean by that? We look not just at the synthetic function of the patient, but the portal hypertensive components. Were we able to recanalize and reduce the HVPG? Were we able to tips and reduce the portal pressures? And remember, with tips, your portal pressures don't fall immediately, as Professor Chavala alluded to, and it may take a few weeks. So, for me personally, at this point, I wouldn't rush and use DOAX. Certainly not within 2-3 days of a variceal bleed or post procedure. I would wait and see, and on select case by case basis, use it. I've already gone through how to that we don't have a way of monitoring. Thank you.
Thank you, Uday. Come and join us. We have the next speaker, Dr. Shivanand from All India Institute. He's going to talk to us on radiological interventions in Budd-Chiari syndrome, long-term results. He was one of the few radiologists who started TIPS at All India Institute many, many years ago, and to his credit, he has trained a number of intervention radiologists who are doing excellent work in the country.
Thank you,
Shivanand.
sir. Thank you, sir. At the outset, I would like to thank the INASL group for having me. So part of it is already covered by Chawla sir. So the definition is very well known. The obstruction can happen at various levels, and the presentation depends upon the site of obstruction and the duration of the disease. Depending, if you see this graph, see before 90s or 2000, majority of these patients were used to be managed by liver transplant or shunt surgeries. So after 2000, everything is IR. If you search treatment for BCS in the literature, it is flooded with IR treatments. Okay, so currently the transplant is usually restricted for as an end stage when all endovascular therapies fail. So where the surgical treatment are offered. So this is a natural history. The clinical presentation depends upon site and the duration. Either they present in acute or subacute, chronic, or ACLF. What we see in our institute is mainly chronic or ACLF. If you don't intervene, ultimately they'll end up in cirrhosis, multi-organ failure, hepatocellular carcinoma. So this is the area where we have to intervene, restore the physiological flow so that we can prevent or reduce the progression of the cirrhosis. So the management is multifaceted. So we have to control the ascites and variceal bleed, identify the hypercoagulable state, treat and put them on anticoagulation, and also we regularly follow these patients for screening of HCCs. So, but having said that, the mainstay of treatment is to relieve the obstruction. That has to be done either by radiological method or a surgical. What I'm going to talk about is mainly the radiological. So we have all the spectrum of procedures at our disposal to treat these patients. So in a short segment narrowings or occlusions, these are easily treatable with plasties. And if there is any residual stenosis or persistence of gradient or a collateral, we treat them by, can I have a pointer? It's in the... Okay, good. Sorry. Yeah. Leave it, okay. Okay, so mainly these are treated by stenting or angioplasties, wherever what we call it as a revascular procedures, mainly for short segment occlusions and narrowings. So the when we follow the stepwise treatment as discussed, so TIPS is reserved for the patients where there is a diffuse disease, which are not amenable for any endovascular treatment, like revascular procedures, or you have exhausted all the revascular procedures, where we do TIPS either using a hepatic vein stump, as in this case, we connected the hepatic vein stump to the portal vein, or sometimes we don't have any hepatic vein stump, we connect the IVC to portal vein, what we call it as a DIPS or a portocable shunt. So that is all about the radiological procedure, what are the spectrum, what can be offered to these patients. Coming to the one of the largest data published in from our institute, which is comprising of more than 500 patients, where these patients were treated by endovascular modality. It was published 2021. So we've collected 701 patients, which includes those patients which were not before the start of these endovascular treatment at our institute. So if you see the data, the combined disease is more common. That is comprises about 50%. IVC is only 6%, and hepatic vein is 44%. That is far different from the Chinese group, where the IVC is more common than our data. So we could offer treatment in 500, did procedures in 510 patients out of 536 when we started in 2005, all these procedures. And the technical success is to the tune of 95%. And if you see the breakup, how the left side medical management days were prior to the interventions, and the radiological interventions, the revascularization procedure, angioplasty stenting amounts to about 70%, the TIPS about 30%. If you go on, because these patients keep on coming to you, we have to do secondary procedures, re-interventions, second intervention, third intervention, four interventions. So sometimes we have done about 4 procedures in one patient, because these patients keep on coming to you with the blocks. So we try to salvage these patients as much as possible. This is another study we published in APT, just to show the breakup again, the success rate with individual procedures like IVC, hepatic vein, with respect to site of obstruction. So the technical success is, see, IVC is much, it is the simplest of simple procedure, even resident and fellows can be done. But when it comes to TIPS, it needs the technical expertise, and the combined disease and hepatic vein alone, so they are more complex and they need a technical expertise, and they have a little, the technical success is little bit less. So if you come to the clinical success, the complete response is about 71, and partial response, where there is a little bit dependent on the diuretics, so that is about 25. If you combine both these, it is to the tune of 95%. Coming to the cumulative patency, the revascularization from first year to fifth year is 88 to 72, and the TIPS is 95 to 68. Obviously, TIPS has got a little less patency rate. That is expected, because you are putting a long stent. The chances of getting rethrombosis is very, very high with the TIPS. Coming to the survival probability, it's almost like at 5 years, it's about 76 to 82%. Nothing comes without complications. The complication rate was 2.1%. So some of these are very, very major ones. And some of them are managed on at the time of intervention itself. Late complication is usually the reblock, restenosis, and we try to do a Doppler, pick up them, and intervene in a timely manner. So we do the revisions either by plasty or putting a restents, depending upon the situations. So unlike cirrhosis, the hepatic encephalopathy is not a common entity in Chiari. We had around at 5 years, it was encephalopathy free period. Patients were about 86%. Okay. And this is a summary of 2 major studies of our. So we have the good patency rate to the tune of 82 at 1 year, 95%, at 10 years is about 50%. And secondary patency, when we do re-intervention, obviously it is going to be, the patency is going to be increased. And the transplant-free survival at 10 years is about to the tune of 78 to 80%. This is already Sir covered meta-analysis just to show the difference. If you see this in this data, the site of obstruction, the IVC is about 31%, okay, and the hepatic vein is almost comparable to us, but the major difference is the IVC, okay, in across the world. And this meta-analysis, the technical success, clinical success is little high because majority of these patients were IVC related, okay. And most of these data, when they included in the meta-analysis, more than 50% studies were from China. And this is one center-to-center comparison from China and our Indian data. So we did about 146 tips in our group, where the Chinese group, they did only 5 tips, because out of 455, they had 425 IVC cases. So most of the IVCs are get away with angioplasty or maybe stenting, but combined and the hepatic vein diseases, they more of land up in stenting and our tips. This is the latest about to be published, where we only studied the tips in Chiari syndrome. It's a multi-center study. We combined with CMC Vellore and Kochi, and we have a total of 318 patients. And we did, obviously, it is a retrospective analysis. So all the patient had tips, and the complete response was about 76%. So there was a pretty 23 to 24% was non-responders. And we studied the complications also, new complications like a new decompensation even after procedure. At 1 year is about 16%, and 10 years is about 30%. And hepatic encephalopathy at 1 year is 7%. So the survival, if you see at the 10 year, it is almost to the tune of 80%. On comparing with those patients who are on no interventions or on medical treatment, if these patients don't receive any kind of endovascular treatment, the survival is very, very dismal. It is to the tune of less than 10%. And also we calculated the predictors. So how mortality predictors, apart from bilirubin and the albumin, so non-response to tips or a post-tips hepatic encephalopathy associated with poor outcome, new decompensation or mortality. So these are the predictors we extracted from our data. So coming to this is the compilation of the major studies. So one of we had 4 studies which are almost like to the tune of 200, and one is the latest one is the 510 patients. So what we can make out from all the data is that what are the predictors for good outcome? Early interventions, if the patient is having a short duration of symptoms, they respond well. Preserved liver function, successful restoration of the physiological flow or hepatic outflow, and controlling of the prothrombotic disorder. If you do this, so they tend to have a good outcome. Wherein if you do whatever the interventions, if the patient is having advanced liver disease, diffuse thrombosis, elevated serum creatinine, or advanced stage, so or you've done a procedure but at 3 months they don't respond, or at 6 months they don't respond, so those patients, they have a poor prognosis. So in such cases, these patients should be subjected to early transplant. So last one thought-provoking debate, whether we should go for a early tips or a stepwise mechanism or a strategy, especially in those patients we have a reconstructible hepatic vein. What we do is that at our center we go for stepwise anticoagulation. If there is amenable hepatic vein, we do it. If it fails, then go for a tips, and then at the end liver transplant. But there is a Italian perspective that one should go for a tips upfront, even though you have a reconstructible hepatic vein, because in stepwise mechanism strategy, even though you do physiological restoration of the flow, there is ongoing ischemic effect. these patients will have ongoing fibrosis. They will land up in liver failure. But that means there is no complete heart of the congestion, so decongestion. So that's why the Italian perspective, they say that one should go for a early tips rather than doing all these stepwise strategy. So, but there is no randomized studies. It is just a thought process. So that needs a validation. So to conclude, so endothermic vascular therapy in BCS is safe and effective with good patency and survival. And the short segment lesions are treated by angioplasty and stenting, whereas combined or hepatic veins, they are more complex, need technical expertise, and they land up in tips. And at this moment, the tips is reserved for a diffuse disease where there is no reconstructible hepatic veins. And early intervention improves the survival. So there is a role for a multicenter RCT to compare stepwise versus early tips in patients with reconstructible hepatic veins. Thank you.
Yeah, if I can ask Dr. Uday. You said that you don't use any DOACs at all, and it's mostly warfarin. So now I know that CMC has mainly a fleeting population. You have a lot of referrals from all over. How do you ensure that they are measuring their INRs accurately?
So I have to clarify. The DOACs may be very anecdotal, 2 or 3 patients as a whole. But in Anand Sharma's study that I showed, all the patients were anticoagulated. We use vitamin K antagonists, but we don't use warfarin. We use acetrom. The reason being the half-life of acetrom is a day versus warfarin is about a week. So to switch on and off, especially when you have a dodgy, child B to C system, theoretically we feel acetrom is safer. One. Two, we don't set the targets very high. It's almost as if we are giving it to satisfy ourselves. So we'll keep an INR of say 1.5 to 2. The rheumatologist insists in an APLA situation go to 3 and then we push ourselves to do that. So really we are not too worried about the monitoring. We are worried more about it going too off. We don't want it, like Madhumita said, we don't want it to go 4, 5 where you know that the liver function is not too good. But to keep yourself happy, moving the INR from 1 to 2, I think is okay. Is it doing extra good? I'm not sure. But like Anand Sharma's data showed, at 5-year follow-up, it didn't do harm.
Now, my question is the practicality of the whole thing, that labs are often not accurate in the measurement of INR. And how does one ensure that? Do you use the finger prick one for measuring INR?
So I'm not the right person to answer that. Dr. Sukesh Nair, our transfusion medicine, no, but I don't think we are using a finger prick technique. And I agree with you that monitoring the way the INR is done
Yeah.
is extremely important. So it may be a difficult problem all over the country. I agree.
Thanks. But on the other hand, DOACs, you are taking a complete chance. You don't know what's happening in terms of the anticoagulants.
DOACs at this point, I don't think we have enough data to recommend it for use for everybody. Not at all. It will probably evolve, but at this point, I think if I give the message that please start everybody on DOACs, I think that would be wrong.
Thank you.
Can I make a comment? Okay, so we've been following your work at PGI. I'm a pediatric hepatologist and gastroenterologist here. So very good results. What practically we face is we do a lot of small kids. Harish is here. He's doing most of our interventions along with Dr. Naveen. So there's a lot of block. I mean, we do the dips. We do a lot of dips because the situation we see is all 3 veins blocked and you're forced to do a dips. So after a few months, they'll block up. And, reintervention is always so expensive. So that brings me back to our old times when I was a junior resident and a lot of surgeries were being done. And but these days, it is very difficult for us to convince any surgeon to do a shunt up in patients who can't afford. So it takes so long to arrange the raw material, the stents, etc., through Ayushman because our patients are abysmally poor. So, and then what we realize is that the shunt is blocked, but there is no ascites. So this is a situation we see very commonly, and one wonders then because then we find a lot of intrahepatic collaterals, and then one wonders that when these intrahepatic collaterals are decongesting the liver, so are we correct in insisting on a reintervention? And should we do it or shouldn't we do it? Of course, the risk of HCC, we have seen a couple of HCCs long term. We have, I think, at least a dozen patients who we saw 15 years ago, and some intervention attempted, mostly blocked, and then they get lost to follow up and pop up again in our OPDs. So we've seen 2 HCCs so far, but the rest of them, they're all well-grown, strapping kids, grown up to be adults and doing extremely well, educated, professionally complete. And so one wonders that with such a high blockage rate, when you do kids, small kids, whether you should be actually running after reintervention or not. So that is my query to you. And about DOACs, we have started giving DOACs in kids, and we are using the same way we monitor for enoxaparin with the anti-10A. The same thing works very well for them. But we have it available in our institute, so we can do it.
Just a comment before you answer. We've seen that the stents which are being used in the last decade or so are not as good as what we used earlier. So when we started doing tips for ascites, not for Budd-Chiari, of course you need anticoagulation. Our IR guys started telling us that because these stents tend to block earlier, the recent ones which are being used, give anticoagulation even to the ascites ones, where one would normally not recommend anticoagulation. Is that your experience, that the stents which are available now are
Maybe
not as good?
earlier stents were base stents, madam, uncovered stents. Now every tips is a cover stent.
Covered
So
stents,
the material is the CPTFE, everything is same material only. Maybe the I don't know the reason, but in cirrhotic patient we don't put them on anticoagulation.
So
But
one
Chiari,
reason
obviously.
maybe ma'am, because nowadays in cirrhotic patient, so we put the smaller size diameter stent, not the 10 mm. Previously we used to put the 10 mm because the HE is the risk associated with tips. So because there is one paper now coming in JCH issue based on this is from the ILBS, the effect of diameter on the resolution of ascites versus stent block. So if you decrease the diameter, of course there is an increased risk of thrombosis, and if you increase the diameter, there will be risk of HE.
No, it's not a change in diameter, I'm sure.
But we have changed. Now we in tips we are using all 8 mm, not the 10 mm. But in Budd-Chiari we use 10 mm only.
So with
For the adult patient, not pediatric.
with your query, madam, if the patient is asymptomatic, so they will behave like a EHPV now. So if your patient is asymptomatic, like a EHPV, they have a good collaterals. So maybe if they develop any varicose bleed, that can be managed by endovascular or endoscopy. But if the patient is having symptoms of recurrence of earlier symptoms, we have to intervene. If the patient is blocked and without any symptoms, you can just follow it up.
I think, Dr. Sadhna, you brought out a very important point. You do get patients who are asymptomatic after they have been stented, and they get a reblock, don't develop ascites because of the venovenous collaterals. I don't think these patients need to be intervened. And same is true for asymptomatic Budd-Chiari. The literature says that these patients should be given anticoagulation and should be decompressed. An asymptomatic guy with collaterals, why do you want to intervene unnecessarily? So this also is a small proportion
we
of.
also doing the same thing.
I brought up the question because I've heard Dr. Acharya saying in at least 2 lectures that why not do it early? I mean, even
So
these
there is
patients
another
should be-
school of thought, sir.
So the AIMS group, some of them think
Another
that
school of thought in the APASL, जो भी Asia Pacific guideline, if there is you have to do asymptomatic patient, you do a fibroscan. So if there is a fibroscan shows there is a evidence of a fibrosis or a high whatever, they say recommend to do a intervention. Otherwise, asymptomatic patient, normal liver fibroscan, don't intervene. That is another point.
So fibroscan has actually been also used for the congestion.
Yes,
I mean, it is you have very high values before the intervention, and after intervention it goes down, and it can be used to monitor to look at
Response.
the efficacy of your procedure. But I'm glad everybody thinks this, because this has been asked me by because some patients will go somewhere else and they'll be, oh, then why they are not doing anything? They should be re-intervening, they should be doing this and that. But we are quite happy with the way our patients are behaving, and so we are not doing anything.
But then why do Dopplers? They are asymptomatic. We keep doing every 3 to 6 monthly
No,
Dopplers
no,
to
no.
see whether they are blocking off.
No. If it is a patent one, you have to do. You
See,
have to
but
identify.
there's no ascites,
Patient
madam.
को कोई symptom नहीं है, तो why
patient
do the
has got
Dopplers?
no ascites, is asymptomatic.
Yeah, exactly.
So we don't do anything.
No.
But Dopplers we do. They come back to us and then we do a Doppler.
नहीं, हम तो बोलते हैं कि every 6 months Doppler करो.
हम नहीं कराते.
नहीं, Doppler तो करना है, madam. That is the follow.
शुरू में कराना है, but after a few years.
No. After intervention also, every 3 monthly we do.
No, we are doing it immediately peri-intervention while we are, but some of them get lost. What I want to say is, some of them will get lost to follow up, and they'll come back to you, and
That is
they
a
come
different
into
issue.
your OPD and they have blocked shunts, and you find lots of collaterals, and they have done well in the last 3-4 years when they have not come to you. So you follow them, and they are doing well.
So sometimes ultrasound in early ascites. Yes.
Listen to the Willow perspective.
So this is something that I think fundamentally, if we look at it from, are we trying to restore a physiological flow, or are we trying to reduce portal hypertension? These are two different questions that we need to understand. So if the attempt is to restore a physiological flow pattern, then on paper, even if a patient is asymptomatic, we should try and restore physiological flow, and that is the Birmingham series, and that is why their tips is much lower, and their devascularization is much higher, and that's our similar experience. On the other hand, if we cannot restore physiological flow, and who decides that? The experts on this side, either with very good Dopplers, maybe endosonology in future, or even a diagnostic venogram. If there is a vein that is openable, then we should try and open it. That way we are restoring flow. On the other hand, if we can't do that and the patient is asymptomatic, then we would wait and see. If the patient becomes symptomatic, then only we will go for tips. So I actually disagree with early tips.
No,
I would say
I am not telling it should be done, but it's a school of thought.
It's a recent literature that's
It's a debate now.
I think
Hot
it's
topic.
UK versus Europe,
Yeah.
and we are now wondering where to go.
We are still doing the step-up approach. So if there is a
think that's
hepatic
right
vein which can be recanalized, we first do recanalization of the hepatic vein, and still if patient symptom don't get away with the recanalization, then we go for the dips or tips.
Since you have a lot of pediatric work, I want to know, we just published our series of interventions in Chiari, which is of infancy onset. And we found that there was a large percentage of patients who developed hepatopulmonary syndrome. Have you
Yeah.
observed that?
So hepatopulmonary, we many of our patients with hepatopulmonary have direct. Sometimes it's a direct portosystemic shunt. So not the Chiari one, but we have the patient. The last one we treated was having portosystemic shunt. So there is no flow towards the liver. Everything is going to that.
Are you saying it after TIPS?
No. This was congenital portosystemic shunt.
I'm saying after TIPS,
Yeah.
they have developed a hepatopulmonary syndrome.
Yes,
Have
so
you observed
that's why I am saying that if you using the larger diameter, it will show the flow will go towards the heart, and it will increase the heart load and ultimately the pulmonary load after the intervention.
Larger means bachcho mein 80. We don't have anything less than 8, na?
No, 6 is also available. Sometimes
it?
you have to
We
order
don't
it.
get 6.
Yes.
The mechanism is almost similar to congenital photosystem
Yeah.
shunt after TIPS. We have also seen in one of our patients out of around 40 patients. So one of our patients who underwent TIPS at around at around 3.5 years of age. So he also lost to follow up, tips got blocked, again recanalized, and then subsequently now he developed severe HPS, and after a year or so he developed HCC. He died of multifocal HCC.
So in after intervention, the patient develops such a symptom, then we have to reduce the size of this.
I think Sadhna, any last minute, because
Just about
just
HPS
about to
business.
close.
HPS is all to do with the portal hypertension. Basically, we see it in a lot of cirrhotics. We see it in a lot of a few EHPVO, and we do see it in Chiari if they have a significant portal hypertension. But what is the clinical significance again needs to be worked out. I mean, we recently looked at our data, and there was a significant number of patients of Chiari who had all related to the endothelial dysfunction, release of nitrous oxide, which opens up the collaterals. So it's not an uncommon phenomenon.
So it's the time
Intervened
for
or
valedictory
Yes. So with
function
that, we
now.
conclude this, and I would like to thank the chairpersons and the speakers. I request the chairpersons to please and the speakers to please come forward and assemble for a photograph. And with that, we'll conclude the academic sessions for the conference, and we'll proceed to the valedictory function at Hall 1.